Hi everyone, this is Doc Ina and this is my lecture on normal labor and delivery. To download my lecture, please go to my WordPress site, Doc Ina Obigaine. Reference for this lecture is Williams Obstetrics, Chapter 22, Normal Labor. So basically this is the outline by which we'll go about our lecture for today. So first off, we have to review some of the terms that we will encounter in this lecture, and these are some of the terms that we already discussed in my previous lectures. So first off, we have fetal lie. Fetal lie describes the relationship of the fetal long axis to that of the mother. So we have the longitudinal lie, the transverse lie, and the oblique lie. So if you see in this picture, picture above, uh, letter A is the longitudinal lie because the fetal axis is along the long axis of the mother. And the picture for letter B, or on the right side, is the transverse lie because the fetal axis is at right angles with the maternal axis. Okay, so fetal presentation is the portion of the fetal body that is either foremost within the birth canal or in closest proximity to it. So we can have a cephalic presentation, a breech presentation, a shoulder presentation, or a compound presentation. Fetal attitude, such as this seen in the upper picture, is the fetal posture or the habitus. Okay. Fetal position, on the other hand, is the relationship of an arbitrarily chosen portion of the fetal presenting part to the right or left side of the birth canal. So for a more in-depth discussion about these terms, if you've already forgotten about these terms, you can always go back to the previous lectures that I already have. So what is normal labor? Normal labor is usually defined as that onset of uterine contractions that bring about demonstrable effacement and dilatation of the cervix. So when does normal labor start? It is that clock time when painful contractions become regular. Okay, so this will depend mainly on when the mother perceives that painful contractions. Okay, and the start of normal labor can also be pegged at a cervical dilatation of 3 to 4 centimeters or greater, which is presumed to be a reasonable, reliable threshold for the diagnosis of labor. So basically, we have 4 stages of labor. The first stage is from the onset of regular contractions up to full cervical dilatation, that's about 10 centimeters. Second stage is from full cervical dilatation up to the delivery of the fetus. The third stage is from the delivery of the fetus to the delivery of the placenta. And the fourth stage is 1 hour from the delivery of the placenta. So the first stage of labor is basically composed of 2 phases, the latent phase and the active phase. The latent phase is the early part of labor when the cervix hasn't yet reached the cervical dilatation of around 4 centimeters. Active phase usually starts when there is already the start of active contractions, usually beginning at the cervical dilatation of 4 centimeters. The pattern of cervical dilatation during the preparatory and dilatational divisions of the normal labor is or follows a sigmoid curve, such as this seen in the picture. So the latent phase corresponds to the preparatory division here, and the active phase corresponds to the dilatational and pelvic division. So there are 3 functional divisions of labor: the preparatory division, dilatational division, and the pelvic division. As you can see here, the preparatory division corresponds to the latent phase. And this is the division when there is slow cervical dilatation and connective tissue components change. Sedation and conduction analgesia may arrest this division. So usually if the patient is still in the preparatory or the latent phase, we don't administer sedation or epidural anesthesia because this might arrest her labor. Now, the dilatational division corresponds to the active phase. Okay, so dilatation proceeds at its most rapid rate, and this is unaffected by sedation. So when the patient is already at the dilatational division, that's when we start an epidural anesthesia or sedation. The pelvic phase also corresponds to the active phase, and this commences with the deceleration phase, and this is the division where cardinal fetal movements take place. The second stage of labor, as I've already mentioned, commences from the full cervical dilatation up to the delivery of the baby. The second stage of labor, as I've said again, begins with complete cervical dilatation and ends with fetal delivery. Its median duration is approximately 50 minutes for nulliparous and about 20 minutes for multiparous. In a woman with a contracted pelvis, however, with a large fetus or with impaired expulsive efforts from conduction, analgesia, or sedation, the second stage may become abnormally long, and this is what we call dystocia. So this is an example of a normal labor curve, or what we call the Friedman's curve. So basically, this graph is composed of the x-axis and two y-axis. So the x-axis, of course, corresponds to the time, and the y-axis on the left corresponds to cervical dilatation. As you can see here, it is numbered 1 to 10, and that means 1 centimeter up to 10 centimeters. The y-axis on the right corresponds to the fetal station. So we have here -5 to +5. Okay. Also, you can see here in this graph are two curves. Okay. The curve going up, the one with the sigmoid pattern, corresponds to cervical dilatation, and the curve going down corresponds to the fetal station. Okay, so as you can see here, when you plot the cervical dilatation, you use circles, and when you plot the fetal station, you use cross or X. Okay, so this plotting will depend on your internal exam for a particular time. So for example, if at a particular time you did your internal examination and the cervical dilatation is at 2 centimeters, and then you determine also the fetal station at -3, then you plot it according to your internal examination findings. Okay, until you reach full cervical dilatation or station +5. Now, doing the Friedman's curve now might be a little bit complex for you, but when you become medical clerks or interns in the future, this will be very easy as you will have a lot of practice doing the Friedman's curve. So now let's go to the management of normal labor. So how do we identify labor? Uterine contractions that are 5 minutes apart for an hour, that is greater than 12 contractions in an hour, may signify labor onset. Active labor is defined as a cervical dilatation of at least 4 centimeters, as I've already mentioned in the previous slide. Women admitted during latent phase of labor had more active phase arrest, more frequent need for oxytocin, labor stimulation, and higher rates of chorioamnionitis. Thus, women who were admitted during the latent phase or less than 4 centimeters had a higher risk for abdominal or cesarean delivery. Now, WHO has its own partograph or plotting of the labor curve pattern. So a partograph was designed by the WHO for use in developing countries such as in the Philippines. Labor is divided into latent phase, just like in Friedman's curve, and the latent phase should last no longer than 8 hours, and of course, we have the active phase, which starts in for WHO at 3 centimeters cervical dilatation, and progress should be no slower than 1 centimeter per hour. Okay, so a 4-hour wait is recommended before intervention when the active phase is or seems to be slow, and labor is graphed, such as this one in the picture, and analysis includes use of alert and action lines. Basically, this partograph was designed by the WHO to help not only obstetrician gynecologists but also the midwives in identifying those patients with abnormal labor patterns. If they are able to identify abnormal labor patterns, then the earlier they can intervene, or in the case of midwives, the earlier they can refer to an obstetrician gynecologist. So we go now to the management of the first stage of labor. So first is a cervical assessment. And when we assess the cervix, we usually assess many parts like the cervical dilatation, effacement, consistency, position, and fetal station. And all of these components, all 5 of these components, are part of what we call Bishop scoring, such as seen here in this table. Okay, what is Bishop score? Bishop score is a quantifiable method used to predict labor induction outcomes. So if you get a Bishop score of 9, that conveys a high likelihood for a successful induction, and a Bishop score of 4 or less identifies an unfavorable cervix and may be an indication for cervical ripening. So the obstetrician gynecologists usually use the Bishop scoring not only in predicting the likelihood of successful induction, but also we use Bishop scoring to identify those patients who might need uterotonics to facilitate labor. So what is cervical effacement? Cervical effacement is the gradual thinning and shortening of the cervix measured in percentage. So when the length of the cervix is reduced by 1/2, we call that 50% effaced. So when the cervix becomes as thin as the adjacent lower uterine segment, then we label that as 100% effaced or fully effaced or completely effaced. Cervical dilatation, on the other hand, estimates the average diameter of the cervical opening measured in centimeters. So we use our 2 fingers, the forefinger or the pointing finger and the middle finger, and then we approximate the cervical dilatation by sweeping the examining fingers from the margin of the cervical opening on one side to that on the opposite side. So the cervix is said to be fully dilated when the diameter measures about 10 centimeters, because the presenting part of a term-sized newborn usually can pass through a cervix that is fully dilated or dilated to 10 centimeters. Now, cervical position is determined by the relationship of the cervical os to the fetal head and is categorized as posterior, mid-position, or anterior. Cervical consistency is determined to be soft, firm, or intermediate if between these two. And finally, fetal station is the level of the presenting fetal part in the birth canal and is described in relationship to the ischial spines, which are halfway between the pelvic inlet and the pelvic outlet. So if you can see here in the picture, no? So the level of the presenting fetal part in the birth canal relative to the ischial spines is what we call the fetal station. So the ischial spines here will correspond to station 0. So if the presenting fetal part reaches the level of the ischial spines, automatically we call that station 0. Okay? So anything above the level of the ischial spines is -5 to -1. And anything below the level of the ischial spines is labeled as +1 to +5. Okay, so +5 will correspond to the fetal head being visible in the introitus. So part of the management of the first stage of labor is intrapartum fetal monitoring or monitoring of the fetal heart rate. So for a patient who is low risk, The fetal heart rate should be checked immediately after a contraction, at least every 30 minutes during the first stage of labor. Okay? If we use continuous electronic monitoring, such as in this picture here, then we can also evaluate a fetal heart rate pattern or fetal heart rate every 30 minutes. Okay? However, if the patient is high risk, then we monitor the fetal heart rate every 15 minutes. Likewise, we monitor fetal heart rate pattern or fetal heart rate every 15 minutes if we use continuous electronic monitoring, such as in this picture here. We also monitor the uterine contractions, and contractions can be both quantitatively and qualitatively evaluated manually. But usually, we use the palm of our hands in monitoring contractions. We can also use, as shown in this picture, an electronic machine to detect uterine contractions. So when we do it manually or by palpation, so usually we use the palm of our hand resting lightly over the uterus. So we take note of the time of contraction onset, and then its intensity is gauged from the degree of firmness the uterus achieves at the height of the contraction. And the peak of contractions, the finger or thumb cannot readily indent the uterus, okay, during a firm contraction. And the time at which the contraction disappears is also noted. So you, if you are the one monitoring the uterine contractions of a parturient or a patient in labor, you note the onset of the contraction and when or the time when the contraction disappears. Okay, so this sequence is repeated to evaluate the frequency, duration, and intensity of uterine contractions. Okay, the frequency of contractions will be from the onset of the first contraction to the onset of the next contraction. So that's what you call frequency. Duration, of course, is the number of minutes or seconds from the onset of contraction to when the contraction disappears. Of course, we have to monitor also the maternal vital signs, and temperature, pulse, and blood pressure are usually evaluated at least once every 4 hours. If membranes have been ruptured for many hours prior to labor, or if there is a borderline temperature elevation, the temperature is checked hourly or every hour. Moreover, with prolonged membrane rupture, that's more than 18 hours, antimicrobial administration for prevention of group B strep infection is recommended. So when do we do subsequent cervical examinations? Periodic pelvic examinations are typically performed at 2 to 3 hour intervals to evaluate labor progress. Now, when the membranes have already ruptured, an examination to exclude cord prolapse should be performed expeditiously if the fetal head was not definitely engaged at the previous examination. The fetal heart rate should also be checked immediately and during the next uterine contraction to help detect occult umbilical cord compression. So how about oral intake? Sips of clear liquids, occasional ice chips, and lip moisturizers are permitted, and food, of course, should be withheld during active labor and delivery. And this is because gastric emptying time is remarkably prolonged once labor is established and analgesics are administered. As a consequence, ingested food and most medications remain in the stomach and are not absorbed, and instead they may be vomited and aspirated. How about intravenous fluids? There is actually seldom any real need for this in the normal pregnant woman, at least until analgesia is administered. An intravenous infusion system is advantageous, though, during the immediate puerperium to administer oxytocin prophylactically and at times therapeutically when uterine atony happens. Moreover, with longer labors, the administration of glucose, sodium, and water to the otherwise fasting woman at the rate of 60 to 120 ml per hour prevents dehydration and acidosis. So for the maternal position, the normal laboring woman need not be confined to the bed early in labor. So in other words, she can choose whatever position she wants. If she wants to stand up, if she wants to just sit down, that's permissible. Okay? So in bed, the laboring woman should be allowed to assume the position she finds most comfortable. And usually this will be in a lateral recumbency most of the time. And she must not be restricted to lying supine because of resultant aortocaval compression and its potential to lower uterine perfusion. Walking neither enhanced nor impaired active labor and is not harmful. So if your patient wants to walk, then you can permit her to do so as long as it's in the first stage of labor. How about amniotomy? Amniotomy, or the artificial rupturing of membranes, should not be done routinely. However, membrane rupture with the intention of accelerating labor is often performed when labor is abnormally slow. The presumed benefits of amniotomy are more rapid labor or earlier detection of meconium-stained amniotic fluid. The ACOG, or the American College of Obstetricians and Gynecologists, recommends the use of amniotomy to enhance progress in active labor, but cautions this may increase the risk of infection, or what we call chorioamnionitis, and maternal fever. Let's now go to the management of the second stage of labor. Okay, so this is when the cervix has already reached 10 centimeters or fully dilated, and the baby is about to come out. Okay? How often do we monitor fetal heart rate at the second stage of labor? Now, as I said, during the first stage of labor, we monitor the fetal heart rate every 30 minutes for a low-risk parturient, but for a high-risk parturient, we monitor it every 15 minutes. Now, during the second stage of labor, we monitor the fetal heart rate for low-risk women every 15 minutes. But for high-risk women, we monitor or auscultate for the fetal heart rate at least every 5 minutes. And usually, we do this, or we do the auscultation after each contraction. So we now go to the management of the third stage of labor. And if you will recall, the third stage of labor involves the delivery of the placenta. So we have what we call the AMTSL, or the active management of the third stage of labor. And this involves the steps. Okay, so we give oxytocin 1 minute after childbirth, or after delivery of the baby. So if you can see in this picture, oxytocin was given intramuscularly, but if you already have an intravenous line in place, then you can give the oxytocin by drip. Okay, not by direct IV, but through a drip in the using the IV fluids. Okay, and also the second step is to deliver the placenta by controlled traction on the umbilical cord. Of course, you can only deliver the placenta if you see or you note the 4 signs of placental separation, which we will discuss next. Okay, and of course, part of the active management of the third stage of labor is to massage the uterus in order to make sure that postpartum hemorrhage is prevented. Actually, all of these steps here are to ensure that postpartum hemorrhage is prevented. So as I've said, before you do delivery of the placenta or do a controlled cord traction, you have to note first the 4 signs of placental separation. And these are the gush of blood, the lengthening of the umbilical cord, when the uterus rises over the abdomen, and when the uterus becomes more globular and firm. Okay? So just a review, we have the 2 kinds of placental separation methods, the Duncan mechanism and the Schultz mechanism. So the Duncan mechanism is when the placental separation happens at the edges of the placenta, and therefore when you deliver the placenta, the maternal or the raw surface is presenting. Whereas in the Schultz mechanism, which is the more common form of placental separation, the separation first happens in the central part of the placenta, so that when you deliver the placenta is folded and the fetal surface is presenting. Okay. Part, of course, of normal labor and delivery are the cardinal movements of labor, which happens during the pelvic division of labor. Okay. Actually, for a more in-depth discussion of the cardinal movements of labor, please refer to my previous lecture on cardinal movements of labor. So I have a separate lecture for just for cardinal movements of labor, and I encourage you to visit my slide deck for that. So basically, we have 7 cardinal movements of labor. That's engagement, descent, flexion, internal rotation, extension, external rotation, and expulsion. During labor, these movements not only are sequential, but may also show great temporal overlap. So first is engagement. And actually, I've already discussed this a little bit in my previous slides. And as I've said, this is the mechanism by which the biparietal diameter of the fetal presenting part passes through the pelvic inlet. And as I've already mentioned, the ischial spines or the level of the ischial spines corresponds to the station 0. Okay, so when the fetal presenting part reaches the level of the ischial spines, automatically that's station 0. So the fetal head may engage during the last few weeks of pregnancy or not until after labor commencement. If the fetal head is freely movable above the pelvic inlet, the head is sometimes referred to as floating or unengaged. A normal size head usually does not engage with its sagittal suture directed anterior-posteriorly. Instead, the fetal head usually enters the pelvic inlet either transversely or obliquely. So again, just to emphasize, the level of the ischial spines is station 0. Okay. So next is descent. This movement is the first requisite for birth of the newborn. In nulliparous, engagement may take place before the onset of labor, and further descent may not follow until the onset of the second stage. In multiparous, however, descent usually begins with engagement, and descent is brought about by one or more of 4 forces: pressure of the amniotic fluid, direct pressure of the fundus upon the breech with contractions, bearing down efforts of the mother, and extension and straightening of the fetal body. Next is flexion. So as soon as the descending head meets resistance, whether from the cervix, the pelvic walls, or the pelvic floor, the fetal head or the fetal presenting part usually or normally flexes. With this movement, the chin is brought into more intimate contact with the fetal thorax, and the appreciably shorter sub-occipitobregmatic diameter is substituted for the longer occipitofrontal diameter. Next is internal rotation. This movement consists of turning of the head in such a manner that the occiput gradually moves towards the symphysis pubis anteriorly from its original position, or less commonly posteriorly towards the hollow of the sacrum. Internal rotation is essential for completion of labor, except when the fetus is unusually small. So next is extension. After internal rotation, the sharply flexed head reaches the vulva and undergoes extension. So when the head presses on the pelvic floor, 2 forces come into play. So the first force is exerted by the uterus and acts more posteriorly. The second force is supplied by the resistant pelvic floor and the symphysis and acts more anteriorly. The resultant vector force is the direction of the vulvar opening, thereby causing head extension, and this brings the base of the occiput into direct contact with the inferior margin of the symphysis pubis. Immediately after its delivery, the head drops downward so that the chin lies over the maternal anus. Next is external rotation or restitution. If the occiput was originally directed toward the left, it rotates toward the left ischial tuberosity. If it was originally directed toward the right, the occiput rotates to the right. Restitution of the head to the oblique position is followed by external rotation completion to the transverse position. This movement corresponds to rotation of the fetal body to bring its bisacromial diameter into relation with the anteroposterior diameter of the pelvic outlet. Thus, one shoulder is anterior behind the symphysis pubis and the other is posterior. And the last is expulsion. Almost immediately after external rotation, the anterior shoulder appears under the symphysis pubis and the perineum soon becomes extended by the posterior shoulder. And after delivery of the shoulders, the rest of the body quickly passes. In summary, we have defined labor, identified the 4 stages of labor, the 2 phases of labor, the 3 functional divisions of labor, and we also discussed how to manage the first stage of labor, the second stage of labor, and the third stage of labor. And finally, we discussed the cardinal movements of labor. Thank you for listening to this lecture, and please don't forget to subscribe in my YouTube channel and my WordPress site, Doc Ina Obigaine.